And Mike also did a lot of research, and I think they said Vanderbilt has a neuro rehab, and that would be the best one. But I asked Emily to text her and check in because Emily said where she is, she goes, she should have come.
But and we are live. Okay. Thank you guys so much for taking care of that for us. We're going to move forward with Module 11, Combating Vaccine Hesitancy in the Louisiana Live Panel Discussion Forum. This is an opportunity for us to engage live to hear our perspectives and to talk about some research we've done in relationship to vaccine hesitancy and share the data with you guys here, what we've done in the state of Louisiana, and get your perspectives, maybe get some thoughts flowing about some interventions you can take back to your communities as well. So I'm very excited about this session. And just a reminder that this is Module 11 of our 11 webinar series, the live panel discussion forum tonight.
Mike.
And again, remembering our team, Dr. Singleton, Dr. Al-Dahir, Dr. Martha Earls, and Dr. Gillard, myself. Again, so excited to see you guys again. And us as a team, as faculty, we have no disclosures in this particular presentation and no financial relationships for tonight. And this live session is for CE credit. It's worth 2 contact hours. And the release date we'll hear about a little bit more at the end of this presentation, but it's worth 2 contact hours. And there's also an application-based CE. So our objectives are here for this afternoon. We have several things we want to discuss. Talk about existing disparities related to COVID-19 outcomes among vulnerable communities. We want to discuss recent research that we've conducted on vaccine hesitancy and acceptance of COVID vaccine among the African American community in Southeastern Louisiana. We want to talk about community concerns and challenges around COVID-19 testing and vaccination, health equity, and trusted sources of health information. And we want to relate all these different things we've discussed today back to you and taking it back to your own community. So we're all going to get a chance to talk and engage tonight. Very exciting time tonight. So with that said, I will turn it over to my first colleague. And we also want to keep in mind that the information we're presenting is rapidly changing, as we know, in the state of the COVID pandemic. So we just want to keep that in mind. So I want to turn it over to one of my colleagues to start on her section on health disparities. That's Dr. Singleton.
Thank you, Chris, or Dr. Gillard. I am going to be presenting to you guys on Objective 1. And so today we'll summarize existing disparities regarding COVID-19 outcomes among vulnerable communities. Before we get started, I just want to bring back to mind the definition of health disparity. And so health disparities are preventable differences in the burden of disease, injury, violence, or even opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And there are many reasons why this can be occurring, multiple factors, but some of them include poverty, environmental threats, inadequate access to healthcare, as well as some individual and behavioral factors, as well as educational inequalities. And I think we'll kind of touch on maybe almost all of them when we discuss what we have coming up. See? All right. It's skipping a slide for me. I'll go back. Okay. Here's an image of the COVID-19 vaccination progress that we have going on across the world today. This is coming from the Johns Hopkins University COVID-19 Resource Center. And so we have here the global graph, and for some reason, it just does not want to stay with you on this global graph for vaccination progress across the world today. And as you can see, the lighter colored areas is going to represent the percent of people that's fully vaccinated at a low rate. So that would be 10, 20%, or 30% and less. That would be the light colored areas on this image. The darker colored areas are going to represent the countries or the nations that have the highest percent of their population vaccinated. And when we say fully vaccinated, going forward, we mean with 2 doses of an mRNA vaccine, 1 dose of viral vector vaccine right now. Okay. Now I'm ready to do our pop quiz. So pop quiz, just to get your blood flowing, make sure everybody's with us. Let's select the correct COVID-19 vaccination progress for each of the above countries. And our options that we have are above 80% of the population vaccinated or below 80% of the population vaccinated. So our first country is going to be Australia. And if you'd like, you can type in the chat whether you think Australia has a population that's vaccinated for COVID-19 above 80% or below 80%. All right, I'm seeing some answers in the chat. I'm seeing above, many above. Okay, let's get the result. That is correct, above 80% for Australia. They have a high vaccination rate in their population. What about Nigeria, you guys? What do you think about Nigeria? Do you think they're above or below 80% for vaccination for COVID? All right, I see some answers below. Many people responding below. All right, I'm gonna agree with you guys. Nigeria has a vaccination rate, unfortunately, below 80%. What about the country Yemen? Yemen. Do you think this nation is above 80% or below? Okay, I'm seeing a few below. I think I saw 1 above. As they're coming in, I'm seeing some saying above and some saying below. Okay, let's go ahead and show it. The answer is below 80%. Yemen actually has a very low vaccination rate. And it's also very low comparatively compared to the other countries in that region, which would be in the Middle Eastern region. There's a lot of conflict that has been going on for several years there and instability. And they have a very low vaccination rate for COVID at this time. Okay. What about Cuba? Cuba, what do you guys think? Above or below 80% vaccination? All right, I'm seeing below. Below, Alexis say above, we got some below. Got a few different things. Yeah, this one's a little mixed too with the responses. All right, the last one I see right now that came in says below. Cuba actually has a high vaccination rate, you guys. It actually has a pretty high vaccination rate for COVID-19. In the Caribbean, it may be one of the highest vaccination rates in the Caribbean. So that's something to think of. And I think this is gonna be our last one, Chile. Chile, what do you guys think, above or below 80%? All right, some folks are saying below. I saw a few above. I think I saw more belows. Another above, below. Below. All right. I'll take away the suspense. It is actually above 80% too, above 80% as well. So Chile also has a high vaccination rate, above 80%, probably above 85%. Thank you guys for participating. All right, so I'm gonna come back to the COVID-19 vaccination progress world map again. As I move through the disparities section, I'm gonna talk about a global scale, and then we'll look at our country, the US, and then we'll look at our state, Louisiana, and maybe some particular regions or parishes in our state as far as the disparity goes. All right, so looking at the world map again, it just kind of echoes what we just talked about as far as the nations with the darker colors being more vaccinated for COVID-19. So we can see if we start from the left that Canada has a high vaccination rate. And these things haven't changed too much since the last time you may have looked at this map, which may have been in the vaccine equity section of the modules that Dr. Al-Dahir did present to you. But you can still see that Brazil, Peru, Chile, also Argentina in our hemisphere, and Cuba, you can see very dark there in the Caribbean. They are very highly vaccinated in these nations, as well as China and several other nations. You'll see them here. I'm gonna go to a listing of the nations to kind of help you visualize it a little bit better. Coming from the same section of our educational resource from Johns Hopkins, we can see that Malta, the United Arab Emirates, Brunei, small nation, Portugal, Chile, Qatar, Samoa, China, Cuba, Bhutan, Spain, these nations have above 85% of their population vaccinated. And while this is kind of like a diverse group of nations, we can say that they probably have a few things in common, or there are some factors that may be lending to them being able to vaccinate a high amount of the population. So these nations are wealthy, relatively wealthy. They may have socialized medication or socialized healthcare. They may also have a strong central government, or government has a strong role in their healthcare system. They may have also instituted vaccine mandates in their country, which is going to lead to more folks being vaccinated in the nation. And then they may have a smaller population size as well, so it may not be as difficult to organize vaccinating an entire population of the nation when it's not so big. Now, I just want to highlight, unfortunately, the least vaccinated nations that we have in the world right now. These are nations with below 10% of their population vaccinated. So we can see that many of these nations are in sub-Saharan Africa. They are African nations. We just talked about Nigeria. Nigeria is probably over 5% vaccinated, but not above 10%. We also have Syria, let's see, Papua New Guinea, Yemen, I mentioned. In our own hemisphere, Haiti is terribly lowly vaccinated. I mean, 2%, that may be 2%, maybe a little less than 2%. So they have very low vaccination rates, even kind of close to us, near to us. And so this is likely coming from poverty, economic or political instability in these nations that is leading to lack of vaccine access. I mean, there's probably many factors here, lack of education, many things there. So these are the least vaccinated nations. I want to take a look at the evolution of COVID-19 cases, and this is on a global scale. This graph is showing you the 10 most affected countries for COVID-19 confirmed cases. So if we look at confirmed new cases, 200,000, 400,000, 600,000, 800,000. And this is also a 7-day kind of case count factor. And we're looking at it over the span of the whole pandemic, kind of from the beginning all the way up till now. And we see that, of course, we had a large surge in January of 2021, kind of around a little before this time, but last year. And so there was a significant surge. And when we're looking at the surge, we're really seeing it occurring in the US, this case surge, because we are this green line that's kind of leading in these cases, which is very unfortunate. Then if we look a little closer to the current time, we just had our Omicron surge that occurred. And you can see that the United States absolutely is leading with a very high number of cases during that outbreak. And there were also a couple of other countries that had a high number of cases, but not nearly as high as us, which would be France, also South Korea and Germany. So there are many nations that are being affected, but we had a very high case count. And we have had a high case count for some time compared to some of the other nations. This graph here is showing us a little bit about the global mortality in the most affected countries. This is just here to show that we've had a pretty significant burden. We in the US have had a pretty significant burden of mortality due to COVID-19. So Brazil and Poland and the US are top 3 for the mortality. And this mortality is reported in deaths per 100,000 of the population, sorry. And so that just means that it's kind of a per capita amount. It's not necessarily that we are the countries that have lost the most total number of people or absolute number of people, but compared to our general population, we have lost a significant amount of people through mortality due to COVID-19. Are you ready for another pop quiz? Here it is. So during the recent COVID-19 Omicron variant case surge of 2022, which of the following was the national COVID-19 % positivity rate? So I'm asking you guys about the % positivity. So during the Omicron surge, what do you think was the national average % positivity rate? So when people were getting tested, what was the % that was positive? Will we say 10%, 15%, 25%, or 35%? All right, I'm seeing some 25s. I'm seeing some C, which is going to 25. I think I saw someone say 35. C, we got lots of C. Lots of C. Jared says B. All right. I see another response for 25. And let's go ahead and find out the answer. The answer is correct, 25%. So most of y'all had that spot on. Spot on. So we had a 25% positivity rate during the Omicron surge. Y'all are very well informed. Congratulations. Here we're looking at some data that talks a little bit more about this. It's showing our national trends for the US. And we're looking at over time, over the full time of the pandemic, the number of cases, the number of deaths, the number of hospitalizations, and the % positivity. The hospitalizations, the deaths, and the cases are being reported in that same 7-day reporting cycle. And the % positivity is just % positivity at that time. Okay, so as we can see in the very beginning of the pandemic, we had a significant amount of deaths. We had a significant amount of high positivity. I'm not sure if the cases were being counted as well back then. We can see a little bump in the graph, but we know that this was kind of like the beginning of our situation. And we had our shutdowns that kind of flattened the curve in between that and our next major surge, which was happening in January of 2021. Okay. And then following that, we had the surge I was just speaking of, our most recent Omicron surge, where we had a significant amount of cases, significant amount of hospitalizations, high percent positivity, which was 25%, up to 26% actually, and we had a significant amount of deaths. If you were to compare this January surge with the last January surge, you see that our curves are much steeper. Our curves are much steeper and higher. And if we look at the deaths, although we have more cases and a high percent positivity, so this may be indicating like more infection is going around. We have more infection or higher infection rates. We did seem to have less deaths occur during this most recent surge than the one that occurred during January and the spring of 2021. All right, so let's continue looking at the United States. Here is a graph, again, from our resource center at Johns Hopkins, that is showing the percent of persons fully vaccinated within each state. Again, the darker colored areas are going to be the states with the most vaccinated population for COVID, and the light colored states are going to be the least vaccinated populations. I can barely see ourselves. It's like we're just kind of melting into a blob of about four to five states down there in the South. That is Louisiana, and we are very light because we have some of the lowest percent vaccinations in the nation. If we look at our whole country overall, our country is about 67% vaccinated at this time. So we are definitely below the goal that our current administration set for vaccinating the population. I think we had a 70% goal by the end of the summer of 2021 or something like that. And we just have not truly accomplished that across the whole country. Some of the more vaccinated states would be California. We see Washington State. I believe this may be, I don't want to be wrong, maybe Colorado. That's dark right here. Hawaii is pretty vaccinated. And of course, if we look on our eastern board, then we definitely have New England being very vaccinated. I believe Rhode Island is maybe the highest vaccinated. And if you include DC, then DC is also highly vaccinated. It might be like the highest vaccination rates there in District of Columbia and Rhode Island. But New England has high vaccination rates. We are about 53.4% vaccinated here in Louisiana, and we rank about 49th in the ranking for the states for vaccination rates for COVID. And we're fourth from the bottom. And just to help you understand how we could be 49th and fourth from the bottom, this listing also includes Washington, DC, and Puerto Rico, which are like not exactly states. So the only states that are below us are Mississippi, Alabama, and Wyoming. Our dear Wyoming right there in the West, Midwest. Okay. So that's where we are right now for Louisiana. Here's another pop quiz for you. Which major demographic group has the lowest rate of COVID-19 vaccination within the state of Louisiana? Is it whites or Caucasians, Blacks or African Americans, Hispanics or Hispanic Americans, Asian or Asian Americans? All right, I'm seeing B. I saw a C. B's and C's. Anything different? I don't see anything different so far. Let me scroll. I saw one person said white a little earlier, but most of y'all are. I'm gonna have to tell you that is actually A, whites or Caucasians. Actually have right now the lowest rate of COVID-19 vaccination within the state of Louisiana. All right, and I can understand why you picked B. I definitely understand why you picked B, because in the beginning of the COVID-19 pandemic, just to bring us back into March and April of 2020, definitely, our state wasn't doing well. Louisiana had some of the highest COVID-19 case rates per capita of all the states in the nation. We also had a disparity for African Americans, particularly who are only about 32% of the population in the state. yet we comprise about 70.5% of the COVID-19 deaths that were occurring at that time. And this is due to existing health disparities in this population, such as increased rates of hypertension, diabetes, kidney disease, obesity, and several more. That's gonna predispose these patients to worse outcomes. And so in addition to that, there was also the possibility or the projection that there was gonna be a lot of vaccine hesitancy in the African-American population. And when polling was done, African-Americans were vaccine hesitant. However, there has definitely been a shift in this, and we are seeing that the percent of the population, based upon this data from Kaiser Foundation, which is kind of recent, when we look at the percent of the total population that's received a COVID-19 vaccine dose, and we look at it by race and ethnicity in our state of Louisiana, we see that whites are actually 56% vaccinated as a demographic group, Blacks 62%, Hispanics 68%, and Asians 99% or greater than 99% vaccinated for COVID-19. And this is really receiving one dose, at least one dose of a COVID-19 vaccine. So as we can see here, there's been somewhat of a shift with vaccine uptake and vaccine hesitancy as far as the populations that we may need to target, because in our state right now, whites or Caucasians and also rural residents are some of those who are least vaccinated right now. I also like to talk a bit about the Louisiana Department of Health data, because when I was looking up some things, I just noticed, they're always letting us know those who are not fully vaccinated and how much they account for the cases, the deaths, and the hospitalizations that we have in our state. And things are really changing with these new variants that are coming out that may be a little bit more contagious, somewhat less deadly, depending on who you are. But right now, those who are not fully vaccinated comprise 48% of cases for the time span of 4/28 to 5/4. 50% of deaths. And I remember a time where this used to be like 85% or something like that. And 67% of the COVID-19 related hospitalization. So this kind of tells us a little bit something about these variants and the efficacy of our vaccines. We are not getting as much efficacy as we used to, or protection, as we have new variants that are coming. And so this also may impact vaccine hesitancy in our communities when patients are thinking, well, I don't need this vaccine, but the vaccines still offer some form of protection from death and hospitalization for our patients. So we still need to encourage them to be vaccinated. All right, I'm gonna look a little at the Louisiana deaths by age group. I just wanted to pull this one out because as I was looking at the numbers for disparities with the Resource Center, I was looking at the age, the deaths by age in our state, and it is so much more than their percent in the population for those that are 60 to 69, 70 to 79, and 80 years of age. Our elderly folks definitely are feeling this mortality rate from COVID-19, so much more than their actual percentage of the population, which would be the gray bar. So the red bar is basically showing us that they're like far exceeding in deaths than they kind of should, than their percentage of the population. And here I just have a little bit by region. If you go to the Louisiana Department of Health, you'll see that we have it broken down by region, by parish, the cases, the deaths, the vaccinations initiated and vaccinations completed. And it's also broken down by demographics such as race. And if we look at Blacks and whites, just speaking a little bit to the data that I talked to you about from Kaiser, we see that we've had a little bit of evening off between some of these things, as far as the dotted yellow line, or kind of like gold looking line, is showing you the percentage of the population that this group is. So if we look at the column of Black and we see the dotted line in Jefferson Parish, we can see that the cases are a little bit more for this group, African Americans in Jefferson Parish, have a few more cases than they comprise of the actual population of Jefferson Parish. And they also have more deaths than they comprise of the population. But the vaccinations initiated and completed, initiated is almost right on target with their percent population, and the vaccinations completed are close. In Orleans Parish, we see the deaths for African Americans outweighing their percent population. But if I go over to the next column, to the white column, we'll see that the colored bars, the orange bars, are not actually touching the dotted line, which is basically, or they're below it or behind it, which is basically meaning that there's less cases, or possibly less vaccinations initiated, less vaccinations completed when we look at this population in comparison to their actual numbers in the community. All right. So there's a lot of information here, and you can go parish to parish. I know you guys are from all over Louisiana. So definitely just visit the Louisiana Department of Health coronavirus information site, and you will be able to find this out. All right, so my last question is, based upon all of the information that we looked at, based upon our information globally, our national information, our state information, and some local information, who do you guys think is vulnerable? And you can just put it into the chat. Who do you think is vulnerable? And who do you think we need to target based upon these disparities? Okay. Someone says elderly, the elderly population. Definitely, I agree. We are kind of already doing that with the booster age being restricted to 50 years and the immunocompromised. I see that. The rural communities, I agree. Yes, so we got a lot of consensus on elderly and the sick and the elderly, seniors, yes. Okay. All right, you guys. Well, thank you so much. This is the end of my section for this panel, and I thank you for your participation. And now I will go ahead and hand it over to my colleague, Dr. Al-Dahir, who is going to speak to you about some of our survey results and vaccine hesitancy. Thank you.
Okay, hello everyone. I am going to go ahead and discuss the vaccine results. Actually, Dr. Gillard, would you be able to advance the screen for me? It's just not quite compatible on the screen I'm using. Okay, if we could go to the next slide. So the majority of our research was conducted throughout 2021. We did the first portion of the research in the first quarter of the year and the second portion of the research in the third and fourth quarter of the year. We're going to look at our research results, particularly with regards to vaccine hesitancy and what would be predictors of vaccine completion or vaccine uptake. This particular grant is targeting African-American community in the Southeastern Louisiana. We do want to distinguish that with regards to the second portion, which is the surveillance portion of the project, that we will not be focusing simply on African Americans. They're actually, we're going to be collecting surveillance data on all demographics of our patient population. Next slide, please. Okay, so this really was, if we look at this, the RADXUP projects, which is the NIH umbrella under which this project occurred, it really was based upon community-based participatory research, and it required an innovative aspect and it required collaboration. So our project is different than all the other projects, and it's because of the help of y'all, in that it is offering an intervention focusing on community pharmacist education with the hopes of increasing vaccine uptake. We also developed a unique survey tool for our community portion of the project, which I'll be presenting. and which has the standard elements of the NIH requirements, but also has elements that are specific to the cultural and demographic nuances of the Southeastern Louisiana region. In order to execute this project successfully, we had to reach across community organizations. We had 6 faith-based organizations, 2 or 3 social organizations, 3 clinics, and 3 pharmacies. We then looked at collaborations. Actually, we used the feedback that y'all provided us in the focus groups and the baseline survey. In addition, we pulled in vaccine experts and public health experts. We also looked, as you met Dr. Sarisi Olatunji West, who has extensive training in historical trauma and in what we would call health-based inequities. And we have a formal research collaboration with Johns Hopkins University. As you may have noticed, some of our collaborators from JH are actually worked on the Pfizer vaccine and were principal investigators in that capacity. Next slide, please. Thank you. So what we decided to do is to analyze our results with the primary predictor variable being, is the individual who's responding to the survey eligible for the vaccine at the time of the survey? So just to remind everyone of the vaccine rollout, which of course everyone has memorized, but of course in December 2020 was limited to healthcare workers. By January 2021, about middle January, the elderly 70 and above, as well as additional healthcare workers, were deemed eligible. By February 2021, eligibility expanded to those who are 65 and above, law enforcement and other first responders, and then special conditions for those who are 55 to 64, teachers, pregnant women, and other eligibility categories. And then finally, by March of 2021, it was broadly available for individuals greater than 16 years of age. So in our first baseline survey, we were conducting the survey throughout this entire period, and vaccine eligibility kept changing as we were giving out the survey. Next slide, please. So we had to define what is our primary outcome variable, and our primary outcome variable was positive vaccine intent. So of course, if an individual had received the COVID vaccine, they were determined a positive vaccinator. Individuals who had signed up to receive the vaccine also were coded as having positive intent. And on a 5-point Likert scale, individuals who said they were likely or very likely to receive the vaccine were coded as positive vaccine intenders. And by the end of May 2021, when we had completed all 487 baseline surveys, it was a 1/3, 2/3 split. 66% of the participants were positive, had received a vaccine or had positive intent to receive one, and about 1/3 were non-intenders. Next slide. So when you're doing a cohort study, of course, we have to see, were there baseline differences based upon our exposure variable? And we determined our exposure variable was the timestamp of, was the individual eligible at the time of the survey? Because we used an adaptive recruitment model in which and that was adaptive due to the changing eligibility for the vaccine, we actually had about a split, about 212 or 40%, 45% were not eligible for the vaccine when they took the survey, and about a little more than 50% were eligible. So were these groups different at baseline? Well, the biggest difference was based on the outcome variable. Those who were not eligible at baseline were less likely to receive the vaccine. In addition, we don't quite understand how this happened, but there were more females in the ineligible category during our recruitment versus in the eligible category. There also was a difference in age, and whereas those who were not eligible at the time of the vaccine rollout were a mean age of 40, which makes sense though, because it didn't fall until the age of 16 until about March or April. So that does make sense. So their average age would be younger, and it actually was significant. But across demographic variables, levels of high school education were the same. Whether they had previously refused a vaccine, like had been offered a flu vaccine by their pharmacist or doctor, those were not different at baseline. Whether they identified as essential workers was not different. And we had a highly insured population. Over 80% in both groups were insured. So the largest differences at baseline, which of course are controlled for when you do the more, when we did our multivariate regression, is sex at birth and age, but age, of course, really was expected. Slide, please. So what are the predictors of someone saying they're willing to take the vaccine? So in the next table, go ahead and go to the next slide. What we have are a list of all of those predictors which came out positive in the bivariate analysis. And this is where I'm not controlling for interactions or effect measure modification or collinearity between any of the variables. I'm looking simply at one variable and then an outcome variable. And what do we see? What is significant when you don't control for other things? Well, we see some interesting things, which I think is what we saw in the community. Women were about 1.5 times more likely to be say they'd be vaccinated than men. Age every year in age resulted in a 1.05 times greater likelihood of being willing to be vaccinated. Eligibility at the time of the survey was 1.6 times. Those people who were eligible were 1.6 times as likely to say they'd be vaccinated. Individuals who had previously refused a vaccine were 0.2 times as likely to take the COVID vaccine. In addition, what we would call high healthcare users or individuals who do not have good relationships with their primary care doctors, we use the primary care doctor as the reference. Whether it's urgent care, individuals who say they use urgent care, emergency rooms, or hospitals as their primary care venue, we found them to be 0.2 to 0.57 times as likely to be vaccinated. So people who are not integrated into the common care model with the primary care physician as their primary touch point were less likely to be vaccinated. Essential workers, we thought it was important to report, but it actually was not significant. And individuals, even though we had a very high insurance coverage rate, but individuals with insurance were 2.39 times as likely to say they'd be vaccinated. So let me ask y'all, are any of these things surprising based on your experience in the community as what would predict positive vaccination or negative vaccination correlation? Are any of these things surprising to anybody? Any of these categories? You can go ahead and type in the chat, or no, not really. It's probably what you've been running into. So go ahead and go to the next slide. What we thought though, and this one has, in my opinion, some surprising results. It didn't matter if the person had received a COVID test. One intuitively would assume that if people were seeking COVID tests, they would subsequently seek COVID vaccinations. That actually turned out not to be related to the likelihood of COVID vaccination. In addition, ever testing positive for COVID, and we were predicting this might go either way. People who would test positive for COVID would be more likely to get a vaccine, or they would be less likely, but we found out when we look at the confidence interval, it actually had no particular impact on their likelihood to be vaccinated. But not surprising, people who've had family that were vaccinated were 2.8 times as likely to get the vaccine. And this one was really odd to us, and I'd love to hear your feedback on how to interpret this. People who said they lost income due to the COVID-19 pandemic were 0.68 times as likely to get the vaccine. So those who had lost a job or lost income were less likely to be vaccinated. What do y'all think about that result? you can actually unmute yourselves. I'd be happy to hear about what y'all think about that result. Whether it's on the COVID-19 test or testing positive or the financial impact. What do y'all think? And don't be shy.
Dr. Al-Dahir?
Yeah, go ahead.
Hi, this is Sean.
Hi.
So in my experience, my patient population tends to be a lot of service industry type workers.
Mhm.
And I'm just guessing that perhaps a lot of people who work in the service industry maybe did not get vaccinated because of just lack of knowledge in regard to the, what the vaccine actually did. Like a lot of people were hesitant to get the vaccine and they only got it just because their jobs required them to. So if they lost work during the pandemic, I mean, a lot of service people did lose work during the pandemic. And so perhaps they didn't go back into that area, or just because a lot of service industry people maybe are not as educated as to how the vaccine is beneficial to them.
Okay, very good. We're still trying to figure it out. And I think that definitely could provide it. And we have Robbie saying that they already lost money and lost their job. What's the point of getting vaccinated? And I think that's definitely possible. Did anybody think that positive testing behavior, as in people who are willing to get a COVID test, would mean they're also willing to get a COVID vaccine? Did anybody think that might correlate? Not necessarily. Yeah, not necessarily.
I agree, Dr. Out here. This is Nandi.
Hi.
With the not necessarily, because I've noticed actually people who didn't want to get vaccinated, willing to get the test to prove to themselves like, oh, like I'm immune without getting a vaccine type of thing, or some people hesitant who have been vaccinated to not get tested because it's like, I'm covered. I don't want to get a positive result and then I can't go to work, or I can't have my child do this, or I'm limited now, so the two don't really correlate in my opinion. It's just whatever they feel.
Thank you. So, but one of the things that did correlate is people who felt that they fell out of the healthcare system were 2.5 times as likely to get vaccinated. And we found that to be very interesting. But a series of things, thank y'all for that fell out as not being associated with positive vaccine intent was knowing where to sign up to get the vaccine, their opinion about the government. So actually, political opinion did not impact in the early 4 months of the vaccine rollout, didn't impact vaccine intent among African Americans. In addition to, perceptions of health inequities did not impact the likelihood. Next slide, please, Dr. Gillard. Thank you. So then what you do whenever you're doing a cohort study, you look at each individual variable, but then you have to do what's called model prediction. So you take all those variables that came out as significant in your bivariate, and then you start running them in different pairs or different groupings together. And you get what's called a best prediction model. And it's a number that's generated with either an AIC or a BIC. Well, regardless, these are the best predictors taken together of why a person would get vaccinated. If they were eligible at the time of the survey, if they were female, if they had previously refused a vaccine, or you could look at that conversely, always accepted a vaccine, if they were underutilizers of appropriate healthcare venues like primary care physicians. Insurance status also is associated in the final model, COVID-19 impact on income, and self-perceived risk, as well as having to postpone care. But even though we take all of these variables together, you could still look at what remains significant in the multivariable analysis when adjusting for confounding or considering effect measure modification. So one of the strongest predictors for likelihood to get a vaccine was if they were eligible at the time of the survey for the vaccine. People who were eligible were 2 times as likely to say they get the vaccine. People who had previously refused the vaccine were 0.14 times as less likely to get the vaccine. People who used emergency rooms were less likely. People who had a low sense of risk, even I just wanted to highlight that because it fell really close to being significant, were less likely. And people who had to postpone medical care were 3 times as likely to say they'd get the vaccine. So why do y'all think being eligible at the time of the survey is so positively associated with vaccine intent? Why is it because, hey, I know I can get it, I think I'll get it, was what kind of the theme of these results are? Does anybody have any input about why that might be? So when you look at the behavioral theory models, it has to do with the contemplative phase of behavioral change. And so individuals who are not eligible for the vaccine weren't even beginning to truly contemplate it. And therefore they were less likely to say they get it. Does that make sense to everyone? Yeah. So then in a sense, the phased rollout might have hurt the long-term vaccination efforts. In a weird way, the phased rollout might have hurt the vaccination efforts. So we'll see. Okay, next slide, please. Okay, so when we did our follow-up, and this is amazing, I'm very proud of ourselves because y'all know we did our follow-up from August to November and the hurricane was August 29th. So it's amazing we got an 85% retention rate. And still 22% of people said they were not getting vaccinated. Next slide, please. And what do we see? We see the reasons are haphazard and spread across reasons that we've all heard. I don't like needles. I don't know how it works. I don't feel at risk. I don't think the pandemic is as bad as it seems. Next slide. It was all over the place, the reasons. 66% of those who are unvaccinated were still expressing concerns about side effects, even though as pharmacists, we consider them benign side effects. Some pain, some tiredness, a headache, muscle pain, but these side effects were significant enough for our patients to say they didn't want the vaccine. Next slide, please. And then finally, we said, well, what will make you get the vaccine? What can we do to make you get the vaccine? Can we give you money? Very few people said money matters. The majority of people said a vaccine mandate by employer or school that would entice them or lead them to getting vaccinated. Whereas about 21% said, doesn't matter what you say, I am not getting the vaccine. So those would be considered the most vaccine resistant. Next slide. And at this time it was Delta right before Omicron. And people were at that time beginning to believe that the vaccine was not effective against the Delta variant. Because it was well known, it was more contagious, higher hospitalization rates, more fatal, very little differences between the vaccinated and unvaccinated with regards to infection rate. So this information, which was coming out in the media, was also driving a lot of their concerns. And the next slide, yes. And so now we're going to go into Dr. Earls' portion on objective 3.
Thank you, Dr. Al-Dahir, and hello, everyone. So now we're going to address some of the community concerns and challenges around COVID-19 testing, vaccinations, health equity, and trusted sources of health information. So we're going to share with you some of the things that were brought out in the community survey. Next slide, please, Dr. Gillard. Okay, so first we're going to address the COVID-19 testing in the community. The survey was showing us that 90% of the participants responded that they knew where they could get COVID testing in their community. Now, mind you, this is our pre-survey, which was done during the January to March of 2021. And so, yes, COVID testing was out there, and the survey respondents stated that that 90% of them knew where they could go to get tested. Now, 85% of them also responded that they had no challenges and no problems with getting a COVID test. Okay, next slide, Dr. Gillard. Okay, we now want to look at previous vaccine refusal, because even before COVID-19, there were some problems with vaccines or immunization uptake. And when we surveyed our participants, the survey respondents stated that 22% of them had refused receiving various different vaccines. Now, 86% of the vaccines that was refused was influenza. 30% refused the COVID-19 vaccine, and 10% refused pneumococcal and the shingles vaccination. So both pneumococcal and shingles have been refused 10% of the time. So we are still seeing that there is work that we can do in order to increase vaccine uptake. Now, we want to now look at some reasons of why the vaccine, the COVID vaccine, would be refused. Next slide, Dr. Gillard. So here we'll take a look at the top 3 reasons why the vaccine non-intenders would not get the COVID-19 vaccine. 28% of the respondents reported that they had concerns about the side effects, just like Dr. Al-Dahir brought forth that there were a number of different side effects that they reported, even though as pharmacists, we do see them as benign. However, that's a challenge to the community. 22% of them reported that they just didn't know enough about how well the COVID-19 vaccine would work. So they had concerns about whether or not the vaccine would be effective. 20% of them stated that They just didn't trust the fact that the vaccine would be safe. So there were a number of other various reasons why they would not get the COVID-19 vaccine. But we've just went over the top 3 reasons. Next slide, Dr. Gillard. So now we just looked at the non-vaccine intenders. So now let's look at the general community's concerns as a whole. So here we're going to look at the top 4 reasons. 56% of the general community had concerns about the vaccine causing severe side effects. So not just the, how we have that tenderness or a little muscle pain, but they had concerns about the vaccine causing very severe side effects. 49% of them was concerned about not knowing what the future side effects would be of the vaccine. So they knew a little bit about what was happening from the research that had been presented, but they were still concerned about the future side effects of the vaccine. 40% of them had concerns that the vaccine was just developed too fast. They could not understand how we just went into this COVID-19 pandemic and already there's a vaccine on the market. So they had concerns about the vaccine coming out too quickly. And the last top reason, we would say 20% of them was concerned that vaccines had not been studied in people like them. So they had concerns that people who look like them were not included in large numbers in the research in order to help with the development of the vaccines. Next slide, Dr. Gillard. And so now we'll look at vaccine health equity. Now, where to get the vaccine, especially those who responded very early. So we're talking about our pre-survey responses, or what we would say our baseline. 37% of them responded that it was not easy to even sign up to get the COVID-19 vaccine. And 29% responded that vaccine locations were not easy to get to. So they had challenges with accessibility of even getting to the places where the vaccines were given. One of our survey questions also asked the respondents or participants how they felt about the state of the COVID-19 vaccinations. 21% of them stated that they just felt confused. They just couldn't understand all of the different things that were going on at the time. 14% of them reported that they were frustrated about everything that was going on. And we also had 9% who really did not care about the status of COVID-19 vaccinations. Next slide, Dr. Gillard. Okay, so when we look at COVID-19 vaccines are being given out fairly in their community. So they didn't have too many challenges or concerns with this because 53% of them felt that the vaccines were being given out fairly in the community. And only 22% sort of disagreed in the fact that it was given out fairly. Next slide, Dr. Gillard. Okay, now we want to look at that same question. What's the current status of COVID-19? Now, this is with our post survey, which was done during August to November of 2021. And we see a difference here because the respondents reported 53% of them was worried about the status of COVID-19. And this is probably because the cases and deaths were increasing because everyone still was not eligible to get the vaccine. 50%, on the other hand, felt optimistic about the status of COVID. They sort of felt that as more people are vaccinated, that things may go back to a new normal, maybe not the normal that we were used to, but maybe a new normal. 33% of them were frustrated. So that's a little bit higher than it was during the pre-survey. And 29% of them stated that they were confused, which is very similar to our pre-survey. Next slide, Dr. Gillard. Okay, so as we know, people use a variety of means in order to find health information, including searching the internet, seeking print sources, talking to healthcare providers, family, and friends. Our survey uncovered that doctors and pharmacists were considered the most trusted source of health information. And this was shown in the pre-survey, as well as if you look at the government, the news outlets, social media, it is a little bit less on the totem pole. Next slide, Dr. Gillard. And this is our post-survey information. So as you can see here, the doctor and pharmacist are still at the top. Now, why do you think doctors and pharmacists were sort of seen as the trusted sources of information? You can put it in the chat or you can unmute. Share why you think. Okay. All right, that we are the experts. That's correct. first line in giving vaccines. Ah, very good. Somebody put their strong relationship, doctor. And yes, that is good. Doctors and pharmacists have a vested interest in being a primary and trusted source of health information. And the reason why we pride ourselves in this is because it is a way to strengthen our patient-provider relationship. And so because we are the experts, because we are the trusted source of information, we have a significant job that we can help to increase vaccine uptake. Thank you so much for listening and engaging as we are now able to identify the community concerns and challenges around COVID testing, vaccination, health equity, and trusted sources of information. Thank you so much.
Thank you, Dr. Earls.
Okay.
Okay, we're going to move on to objective 4, which is basically our active discussion, our active engagement for this evening. Objective 4 talks about relating vaccine hesitancy research to things we just discussed in tonight's presentation, and the lessons learned presented by our panel to potential pharmacist intervention strategies to optimize vaccine acceptance in the community. So putting all the pieces together, how do we use it is our ultimate goal now for the remainder of our panel discussion. So where do we go from here? We've had 11 modules of education that have related to many different topics related to vaccine hesitancy, related to vaccine equity, health disparities, and even more. Dr. Olatunji talked about historical trauma, the reasons why there's trauma involved in related to healthcare. Dr. Singleton talked about COVID-19, the vaccine itself, storage administration. We had Dr. Clement talk about COVID pathogen and treatment options. So we had many different things. Some of our Johns Hopkins representatives talked about vaccine clinical trials and so forth. So we have many different things in this educational series. So now was the time to put the puzzle pieces together and apply it to our community pharmacists and our practices. So how can the elements of this program be applied to your role as a community pharmacist? This is our ultimate goal at this particular point. And it's important to keep in mind in 2022, with COVID-19, we still have some concerns, some things we need to address or target. We are still in the pandemic. We still have to vaccinate. We still are pharmacists providing care in the community. Dr. Singleton talked about vaccination rates. In the state of Louisiana, over 46% of the state of Louisiana is still unvaccinated. We have the 4th lowest rated nation, as was talked about earlier. And we're now talking about boosters for the vaccine. Only 21% of Louisiana residents have received the recommended COVID-19 vaccine booster. So, and also we have projections of another COVID-19 fall surge, where we have some interesting projections that show we may be looking at 100 million cases of COVID this coming fall when temperature starts to drop again. So we see all those things to say that COVID has not gone away, and there's still a need for our patients to get vaccinated to protect themselves and their families going forward. So what can we do as pharmacists to address vaccine hesitancy? There are many different themes that are happening here, and I'm hoping the wheels are turning as you guys have been able to go through the modules. And I actually pulled these common themes from the discussion boards. I was really interested and excited to read your discussion boards in the educational series, and the theme about pharmacists addressing vaccine hesitancy. These were the common things most pharmacists mentioned in the discussion board for the educational series: providing accurate information to patients, staying current on vaccine information, staying up to date, having an honest and open dialogue with patients, building trust and rapport, and avoiding forceful dialogue. There are patients that come to the pharmacy that do not want to get the vaccine. That's okay. It's important to be, I have an honest and open dialogue, and also to listen with empathy. Those were the common themes that were addressed in the discussion board, I gather from the educational series that you guys mentioned. So what do we want to do is, how do we go from taking these themes discussed in the educational series, how do we put it in practice into potential interventions that you can use in community pharmacies? That's where we want to go next. So with that said, we want to open the dialogue up for discussion this evening with some questions, and we want to hear from everybody to get their thoughts, their thoughts going forward, where we are now. How do we go with interventions? What do we do to get our people vaccinated? So we want to start with some questions before we do breakout rooms. The first question is, let's think about people that have refused the COVID-19 vaccine in your pharmacy. What were the reasons why? Were they similar or were they different compared to the data presented today in the panel? So Dr. Al here talked about our vaccine non-intenders, reasons why people do not want to get the vaccine. So in your experience, are the reasons we saw, for example, side effects, concerns the vaccine was developed so fast, those were some reasons why people didn't want to get vaccinated. Is this similar to what you're seeing in your community, or is it different? So let's start with that first question, and feel free to put this information in the chat or even chime in. Okay, I see we have some things in the chat. So most people are saying same reasons in the chat, similar things as discussed in the data we showed tonight. Again, yes, same reasons that are kind of repeating themselves over and over again. Long-term side effects, trust of the vaccine. Does anybody have any different reasons, any unique reasons why a person did not want to vaccinate that they want to share? Or is it all similar? Or does anybody want to have any comments about this first question? They were saying not trusting government or political reasons. Yes. So those same themes are coming up over and over again. Robert's talking about long-term unknown. Adrian mentioned they don't prioritize it. Interesting. Adrian, can you share more about that comment? They don't want to prioritize, they don't think it's priority. Can you tell us more? And feel free to unmute as well too. Government reasons, political reasons, okay. Okay, I see Adrian's comment. But Adrian mentions in a comment that, you know, people have to take off from work or school, and that is a challenge in getting vaccinated. I can definitely see that being a portion of it as well too. Thank you for sharing that, Andrea. So we also talked about vulnerable groups tonight, or disparities that are happening with COVID-19. So we talked about what we saw in our data. What about things you've seen in your community? What have been some disparities that you've seen in community? Well, who are the vulnerable groups you've heard from you, or what are some other things that you have concerns about related to COVID-19 disparities in your community? Okay, I see Robbie is mentioning people with lack of transportation, which is still a very big barrier to this day. Monty is saying this as well too. People that can't get off work in time to get the vaccine. So that is kind of falling under the lines of vaccine access or vaccine equity. So people are still seeing those things to this day in their community practices. Anyone else want to share? Mr. Menino is saying it varies by area. Can you tell us more about that? And also Adrian is mentioning younger generation because they don't see themselves as vulnerable. Mr. Menino saying different infrastructure plays a part. Interesting, very interesting. Kristen is mentioning many patients are concerned about being sick or under the weather at work with the side effects of the vaccine. So there's still a valid concern going forward from our patients. Very interesting.
Dr. Gillard?
Yes, go ahead, Sean.
I have a comment.
Sure.
Some things that I notice when I speak about scheduling, especially right after the vaccine rollout, I felt that there were a couple of different issues. Number one, there was issues with staffing at pharmacies, and therefore patients who didn't have access to the scheduling tools available that were put in place by the pharmacies, they had difficulty getting vaccinated because due to the high demand, walk-ins were turned away a lot, unfortunately. And so we would advise patients, oh, well, this is how you have to schedule your vaccine. And a lot of them say, oh, well, I don't have internet on my phone or what have you. And so there was a lot of difficulty for people to even understand how to even schedule the vaccine. And unfortunately, walk-in vaccines were just kind of very few just because of the demand.
Thank you for sharing that, Sean. It's very interesting. So we have some internal barriers, some system barriers that play a part in that may have had a challenge in negatively affecting people's ability to get vaccinated. And Sean, my question as well is, do you feel like that barrier has been adequately resolved as of today?
Not
or
at all.
anyone can comment.
No, I don't, because we are still dealing with a lot of staffing issues. As a matter of fact, we are very short-staffed, and a lot of our staff are also getting sick with COVID. I had to fill in today for a pharmacist who was out with COVID.
Oh, wow. So staffing issues still are a pretty big barrier going forward. Thank you for sharing that. And also in the comments here, I'm definitely seeing some comments here. So Alexis brought up a good point about younger patients getting vaccinated so they can travel. Very interesting point. As we are starting to open things up a little bit more, people want, more places requiring you to show proof of vaccination and not have any challenges getting to the destination. We're heading to the summer and people want to do summer vacations. So that could be something there. Alexis, do you care to comment or add any further comments there?
Hey, so I've seen a lot more younger patients coming in saying they are going to get vaccinated because they want to travel abroad or travel to other places. And otherwise, if they didn't want to travel, they probably wouldn't get vaccinated. So as I think, like, as the summer months come and people want to vacation more and more, I think more younger people are going to come because they want to travel and have fun again.
Yes. Thank you for sharing that, Alexis. Definitely something that's happening now compared to when we're doing things earlier, starting this series. More things are set up. You have to get vaccinated to move forward, go to concerts, travel, and so forth. Thank you for sharing. Christine made a comment. Some just hear about the side effects and make up their mind instead of researching it. So Christine, with that, what is your approach if a person comes to your pharmacy and has not heard the best information about the vaccine? How do you turn it around potentially as a pharmacist? What are your thoughts about it?
Well, I just try to educate them, or I ask them what questions they have that I could try to answer for them to try to simplify it, because they get confused when they listen to the TV, and it's overwhelming to some of them.
Mm-hmm. Yes, thank you for sharing that. So education is coming back as a recurrent theme as we talk about making interventions to improve vaccine uptake. Thank you for sharing. So moving on to our next question, all very excellent comments. With our panel discussion today, what is one thing you've learned from today's panel in the presentation of the data that you did not know? What is one thing that you've learned today or this evening that you did not know about COVID, or, things about, how our participants were in the surveys, or something interesting? Okay, Alexis mentions the low vaccine rates worldwide. Kristen and Robbie are talking about the change in the trend of the rate of who's vaccinated versus unvaccinated in the state. Interesting. Christine talks about the low vaccine rate in Africa. Okay. Okay. Yeah, so we learned some great stats, some great things going forward, some very unique things going forward, and especially about our state. Last question before we go into our breakout rooms, based on the research and information presented, how do you plan to supply this information going forward in your community pharmacy practices of vaccinating pharmacists? So the things we discussed in our data and the presentation, also the educational series, how would you apply this going forward? Or the data we talked about today, what are some things that you would take back to your communities, or are there some things you would take back to your communities? So how do we apply this information going forward to our communities? Christine talks about research the COVID vaccination rate in our parish. Okay, that is awesome. The Louisiana COVID dashboard has a wealth of information that you can find out the information about your area. Amelia's talking about a really good intervention. Talk to patients prior to vaccination, talk to patients at checkout. That's awesome. That's a really good intervention, a very easy intervention to do. I see, pass those things on to others. Let them know the facts that you learned about tonight. Very good. Indication with customers. That's also a very important one. And we talk about boosters. So our vaccines are very effective, but we know we have some waning efficacy, and that's why we have recommended boosters. Nandy is saying being more proactive with counseling, which is a very important concept. So as we're counseling with new prescriptions, make sure we brush over to talking about vaccinations. Very good comments here. Now we're going to move forward with our breakout rooms. And we have 3 questions. We're going to divide you guys up into rooms to engage with each other and to talk about things that you can bring back to communities. We really want to focus on 3 questions. The first question is, what is the current state of COVID-19 vaccination in your community? How does it compare to when you first started administering the COVID vaccine? Concerns and challenges around COVID-19, vaccination in community pharmacies today. What are you seeing with your patients? And last but not least, discuss at least 2 interventions activities you would like to incorporate in your community pharmacy to optimize vaccine acceptance based on the COVID-19 CE model in the live panel today. So question 3 is our bread and butter question. Based on the education model series and also what we discussed tonight, what are 2 interventions that you want to take back to your community to improve vaccine uptake? So these 3 questions we want you guys to discuss amongst yourselves in your breakout rooms to think about interventions and what's going on out there now. So with this said, we'll start our breakouts. Okay, let's see.
Dr. Gillard, maybe we could do about, I don't know, 6 rooms?
Maybe 3, because we
I
have.
think just 3?
Yeah, about 6 to 7, well, 7 to 8 people per room.
Okay.
Because we have 23 people besides us.
Okay, and I'm just going to assign it manually. I mean, I'll let it assign automatically. actually.
Automatically. Mhm.
Yes. Okay, we'll see you guys back from your rooms in about 10 minutes or so to discuss those questions. Jump into the rooms here.
Right. Okay, everyone, if you didn't write your name in the chat at the beginning, please write your name in the chat now to make sure that we can correlate it with the proper name in the module 11. Please,
Yes,
in our bright space, please.
yes. Maybe George, someone is on a phone called like PCL or something, CPL iPhone. Please give us your name in the chat.
Thank you.
Thank you.
All right, then it seems like we all had some great thoughts in our breakout rooms. We have some potential interventions going forward. It seems like we should be moving toward a wrap up, Dr. Al-Dahir, for your survey.
Yes, yeah, everybody. So we had some good interventions. If maybe one person wants to talk about the
Yes.
interventions, about 2 minutes, and then to go into the survey. Yeah.
Okay, so anybody want to share their potential interventions? Or any of our teams want to share the interventions?
The one that stuck out the most to me was getting the whole pharmacy crew, the clerks, the technicians involved, asking them, hey, do you know we have the COVID vaccine? Did you get your COVID vaccine? Just questioning more of the customers when they come in.
Mm-hmm. So creating a pharmacy task force. So everyone has a role. One person advertising the vaccine, one person talking about what we have, and the pharmacy student education. Okay, great. Anyone else?
We talked a lot about making sure that you maybe offer the COVID vaccine or booster with whenever they're coming in for another vaccine, trying to capitalize on that, because you don't want to have to make them come back another time. If they're already willing to get one vaccine, remember to just double check, have they had their COVID booster? Is that something we can do? Have you had it this series at all? And try to do that together.
Okay, so I think we're talking about grouping the vaccines. Great. So we're going into the fall and we'll have flu again. And then also catch them for the COVID booster or wherever they are in their COVID series. Awesome. Okay. Well, all great interventions. Anybody else have any comments before we move forward in our closing? Okay, great. We had some good comments. I thank you guys for being active participants in a breakout group. So let's move on to wrap up instructions. So as far as earning your credits and certificate, so after the session, the Module 11 quiz should be visible to you. It's a very simple quiz that you complete. Following the quiz, complete the session evaluation. Once all modules, quizzes, and evaluations have been successfully completed, you will be awarded your certificate. CE credits for individual modules should be visible in NEBP within 60 days of completion. And also we have a deadline of until May of next week, Dr. Al-Dahir, Dr. Singleton?
Yeah, I think it may be on the next slide. I think we have to
Here it
choose.
is, yes. So if you have not completed the preceding modules, modules 1 through 10, please do so by the deadline of Tuesday, May 24th at 11:59 p.m. So we have until May 24th to complete all your modules and get your certificate. Now we're going to start talking about the weekly surveillance.
Okay, Dr. Gillard, I'm going to go ahead and share my screen. So I am going to highlight the increments in which we're going to be collecting or reporting the information. Starting in June, you're going to get an email that's a reminder to do the weekly surveillance survey. And it takes about 8-9 minutes, and you'll do it for about 14 weeks. So when you do the math, it really is something close to $500 an hour just for completing the weekly surveillance survey. But it's important to go ahead and look at how we're reporting the stuff. So I need to get the stuff in a numerator and a denominator. Our numerators are either going to be in hours or in prescriptions filled as a standard denominator, and our numerator, that's our denominator, and our numerator will be the number of vaccines offered. So let me go ahead and share what it might look like. Can Dr. Gillard, I'm going to go ahead and take control. Here we go. So the first thing you're going to do is put your name in. Hi, my name's Sara. Okay, we'll put your whole name in. Let me do that properly. It is going to be individually linked to your email, so we have to make sure your email is confirmed, but we're going to confirm there. And I want you to choose all the places you've worked, because the set of questions will generate for each of those places. But I primarily work in an independent pharmacy, but if I work in independent and chain, I would choose both. And you're going to get the repeat set of questions. So I worked 28 hours. And this is saying on average, how many pharmacists do I usually have with me on shift? Actually, when I work, I'm by myself. I'm the only pharmacist, so I put 0. Now, let's say half the time I have another pharmacist and half the time I don't, I will put 0.5. You can put half persons in there if that's the average. If half the time you have one person and the other half the time you have 2, on average, you have 1.5 people with you, okay? And so that's okay. How many students and technicians do you usually have? So we're pretty standard. We have about 2 per shift, always with us. Technicians and students combined. How many prescriptions do you fill per hour? So what I'm going to do is I'm going to take this per hour and multiply how many hours you work. But for you, so I know in this store I work in, we do, let's say 200 scripts a day, and it's open 10 hours a day. So that's, most people know they do about 20 scripts an hour. Do y'all feel comfortable answering that question? This is the average number of scripts you fill a day, an hour, but if you know how many you fill per day, and generally how often how long your shifts are, whether it's 10 hours or whatever, you should have a good idea of how many you're actually doing per hour. Is that okay for everybody? Well, how do y'all feel about that question? Because I was going back and forth on that one. Is that easy math to do?
Yes.
Yeah, I mean, I think most people kind of know how fast they're going. I know. Yeah, it's fine. Good. Okay. How many vaccines did your students provide during this week? So this week, so you might want to keep like a little notepad next to you while you're working and just tally up the numbers. So you could put this at the end of the week. This will come on Sundays because our week is going to be defined as Sunday through Monday. So it'll come for you to record your answers on the Sunday when the Saturday ends. Sunday through Saturday, excuse me. So how many vaccines did your student or your technician provide for this week? So let's say we gave 40 vaccines out. So we didn't give any adult 1. We did maybe 8 adult 2. We did about 5 primary boosters, 5 secondary boosters. I didn't do any, let's say I only did 2 children here and 2 of this completing the series. The children are not eligible for booster, but we know that might change. So I put it there. We also know these categories, again, the default is 0, so that's okay, all right? But it might change over the summer, that's why I put them there. And we know that this might also be the default 0, but just realize it might change. Let's say I actually gave out 10 flu shots, 3 pneumococcal, 1 shingles, 2 tetanus, okay? So the best way to do this is kind of keep a running tally in a little sheet of paper, or most systems you're able to kind of pull out what you did. So we want to know how much you as an individual or your students or technicians that are under you, because they all report to you, how many vaccines they provided during the week, okay? And then the next set of questions is, do y'all give COVID tests? Yeah, we do both. How many tests did we do this week? Let's say we did 20. And then, did you have any vaccines that you offered were refused? And again, I kept trying to give the COVID primary series. 10 of them were refused, and 10 of those boosters were refused. And the kids, they refused that, and 5 people refused the influenza. So just realize, don't put the 5 here because it'll be 50. So you make sure to get rid of the 0, and we'll call you if there's outliers. And what were they saying? It doesn't work. I got the primary series. I don't need the booster. I have a religious objection. Let's say when it comes out for children, it might cause autism. I'm just going to wait for the next surge before I get the booster or the vaccine. And that's it. So that's going to come to your email, and we'll send reminders if it's not done. It's about, you could probably do it on your phone as well, and it'll take probably less than 10 minutes. We're also going to send, just because some of y'all might have changed jobs and everything, we sent you a survey in August or September. It's going to be a shortened version of that to see if you're still working kind of in the same arena you used to work in, just to capture that. Okay, any questions on that survey?
In the chat, Dr. Al-Dahir, they were wondering if you could send the survey in a Word document or a PDF so they could kind of have the paper to make sure to remember the categories that they need to remember for the vaccine.
Oh yeah, like a little cheat sheet that they could just write their numbers down. Perfect, I can do that, yes. We'll probably post it in Brightspace and send it as an email. Okay, that's all for me.
Okay, so just some follow-ups here. These are the survey links. We also have another opportunity for a focus group. That'll be optional to hear where we are now with this whole COVID situation. We did focus groups with you guys earlier in the year. We have another one, a focus group 2, that's a post follow-up. That'll be October 2022. So if anybody's interested, you'll be hearing more about that from us. And likely will be an incentive to participate in the focus group as well. And payment for completion of your weekly surveillance will be somewhere between October and November 2022, the $1,500.
We'd also like to let you know that this counts for 2 hours of live CE, and we were able to reach out to the Board of Pharmacy, and for the last couple of years, the live CE requirement of 3 hours of a 15-hour set, has been waived due to there being less live CE opportunities, and they will be waiving that again this year. So by completing your certificate program, all of your modules, and completing this session, you have earned the required amount of CE for your license this year.
Okay, so if there's no more questions, just some resources for more information, and we can definitely make this presentation available to you going forward. But we really thank you guys so much for hanging in there with us tonight and being proactive and interactive in your chats and discussions. We really appreciate all you do in this presentation, all you do in your communities. We know our roles as pharmacists are extremely important. So thank you guys so much.
Thank you all.
Yeah.
Good night, everybody.
Right.
Good night.
Good night.
Good night.
Night.
Good night, Sean.
Good night, everybody.
Thank
Good
you.
night,
Thanks,
Mr. Ricky.
Okay, I'm gonna stop the recording.